This is the Mayfield brain and spine version of the evaluation and treatment of Chiari malformation and all its associated entities. So I'll do my part, and then Lisa will come up, and then we'll switch back and forth. But I'm going to give you a basic introduction to Chiari malformation, and some of this may be repetitive, and I'm sure Nicole knows an awful lot about this. But one of the causes, we think, is that there is a crowding or some anatomical variations in the anatomy of the brain, particularly the back of the brain. So the brain has basically two components. The top part of the brain has the hemispheres, which control emotions, which control motor function, sensory function, visual function. And then there's a lower compartment in the back of the brain, and that is a small compartment, and the brainstem comes through that compartment, and the cerebellum, which manages motor function coordination, is located in that area. And at the bottom of this compartment, there's a little opening. It's like a drain. And in that opening, the brainstem comes through, leaves the skull, and enters the spinal canal. And the spinal cord goes all the way down to the base of the spine. And so on the left side, you see the cerebellum. That's the back compartment. That's the lower compartment. And on the right side is you see an anomaly where the cerebellum is kind of squeezed down. And so there's not enough room in that compartment. And this probably happens over a period of time, or maybe even happens before birth. But part of that cerebellum, called the tonsils, which is two little protrusions about the size of my thumb, are actually pushed down through that opening, the drain, the foramen magnum. So the brain and the spinal cord actually float in water, and there is a circulation. The brain produces about a pint of spinal fluid a day, and that flushes around the surface of the brain and actually circulates all the way down into the spinal canal. So that spinal fluid is flowing, and it flows around the brain and the spinal cord through that opening, through the drain. And then the spinal fluid is reabsorbed, so there's an equal amount of absorption and production. So there's always fresh spinal fluid bathing the brain, and the brain floats in that. And then what happens is the brain pulsates. So when you open the brain and look at the brain in surgery, the brain is pulsating with every heartbeat. And that influences and has some secondary effects on the flow of spinal fluid. So the spinal fluid is circulating all the way around the brain, and that's a very important mechanism that leads to the basis of Chiari malformation when that gets blocked, when that flow gets blocked. So there are probably a number of different things that cause a Chiari malformation, not just an abnormal shape of the brain, but probably things that we don't understand very well. And so the first thing that happens is the cerebellum begins to plug that opening, and then that process can just evolve and develop into, severe problems for patients. So there are various signs and symptoms, and I'll have to say, of all the entities that we deal with in neurosurgery, this is one of the most confusing for surgeons. For neurosurgeons, it's confusing. So can you imagine primary care doctors, they tell you to Google it because they don't understand it. And then when you Google something, you get way too much information, right? And it's like, how do you interpret that? So there is a variation of symptoms, a wide-ranging variation of symptoms and how they manifest themselves. But probably the major symptom, the most prominent symptom, and the symptom that drives patients to get a diagnosis is headaches that occur from blockage of CSF. And these headaches oftentimes are precipitated by stressful physical activities, okay? And those stressful physical activities make that blockage temporarily worse. So coughing real hard or straining real hard. Oftentimes it can occur when you're constipated and you strain, and that blocks and intensifies immediately the flow of spinal fluid. Physical activity, exertional activity, all of those things can cause the precipitation of these headaches, and it can be associated with neck pain. And then there are all these other symptoms: balance, sleeping difficulties, swallowing difficulties, facial pain. Those are symptoms that are related to the cranial nerves that come out of the brainstem in that posterior fossa, which is the compartment where the Chiari is. And probably what happens is those nerves that come out of the brain and then go through these little openings in the skull to go to your face or to your ears, they get stretched and they get irritated in ways that doesn't happen in normal people. And that's why you get so many different manifestations. It's less certain how memory problems, thinking, cognition, fatigue, or depression, it's a little bit less certain about how those symptoms might be directly related to brainstem compression. But numbness or weakness or pain in the arms or legs, that's compression of the spinal cord where it exits the foramen magnum, the drain, and it's getting squeezed. The brain and its contents are very soft and they're extremely delicate. That's why in evolution they float in water, because they're protected from the shocks of daily living. It's quite ingenious how that evolved. So our major way of diagnosing this is with an MRI. And I'll tell you, the MRIs, before 1985, we didn't have MRIs. And so the diagnosis was much more difficult. I'm not sure how they diagnosed Bobby Jones's Chiari. But anyway, the MRIs show this wonderfully. And you can see here on the left side, kind of a normal posterior fossa where the cerebellum is and the brainstem and all those structures are. And then on the right side, you can see a Chiari malformation where that line is drawn across. That line demarcates the drain. And so above that is the skull, and below that is the spinal cord. And on the back side, you can see the cerebellar tonsils pushed down below that line. That's extremely important. So this is a very impressive slide because it shows a variation of the tonsillar herniation, as we call it. And the slide in the middle, again, that line goes across the foramen magnum, and on the back side of the brain you can see where the cerebellar tonsil is herniated. And on the right side is a very extreme form of that. Now, this is the study, and probably this is the most important slide in this whole presentation. It's a Cine MRI. So what they actually do is they make changes in the MRI with special software, and this actually is showing the pulsations or the flow of CSF. And if you look on the left, on the far left side, you can see a normal flow study, and you can see where the cerebellum is. You can see the pulsations, and you can see the fluid in the front of the brainstem and in the back, and actually you can see it all the way up around the top. And in the middle study, it shows a small Chiari where it's 5 millimeters tonsillar herniation, and you're not seeing the flow so well. But this picture on the right side is the killer picture. This is the most profound way to demonstrate what's actually happening in the brain. So you can see what's called pistoning. You can see the cerebellar tonsil. You see it bouncing up and down? It's going up and down. On the back side, on the right side. And
where you have a pointer.
And that is right here. So the whole brain is under tension. It's under the tension from the heartbeat and the flow of CSF being blocked. Right there, that is squeezing the brainstem with all of its structures, and it's that kind of compression that manifests itself with all the variation of the symptoms that are possible in varying degrees and severity from patient to patient. Now, this is very difficult to explain, but quickly, in the center of the spinal cord, there's a little slit that forms during development in the womb. And that slit actually connects to the top of the brain, right where you see the word Chiari. And spinal fluid is pulsating up and down. When the spinal fluid is being blocked from pulsating up and down the spine, it starts going in that little slit. And that constant pulsation day in and day out actually causes that little slit to start expanding like a little balloon you blow up. And that creates a secondary problem. You see it right there. That's called a Syringomyelia. And that becomes so profoundly dilated that it begins to cause spinal cord compression. And then you get serious repercussions from that. Development of numbness and tingling, weakness in the legs, difficulty controlling, as you see here. And the classic is you feel numbness like over the top of your shoulders, like you're wearing a cape. And this can progress to severe incapacity. And maybe that's what happened with Bobby Jones. We don't have the documentation to show us that, but that fits a progression to an end stage of a continually expanding syrinx, loss of spinal cord function. There are other associated conditions with Chiari malformation. I'll just mention them quickly. They're all very complex disorder, but hypermobility syndromes, Ehlers-Danlos, is associated with Chiari malformation. There's a secondary problem of primary hypertension in the brain, too much spinal fluid pressure that causes the tonsils to herniate. And then at the other extreme, you can actually have a spinal fluid leak somewhere, and your spinal fluid keeps draining out of the brain, and your tonsils sag down through the foramen magnum, and that also causes the appearance of Chiari malformation. Sometimes these hereditary disorders, even though they don't present with Arnold-Chiari malformation, they have symptoms that can mimic Chiari malformation. Multiple sclerosis can mimic Chiari malformation. And actually, too much surgery for Chiari malformation, removing too much of the part of the brain or part of the skull, which I'll talk about in a few minutes, can lead to the brain sagging down. And so surgery is a very delicate proposition, and surgery can result in the causation of problems. So there are two groups that are very simplistic: non-surgical treatment or surgical treatment. So patients may have Chiari malformation but have minimal symptoms or minor symptoms or hardly ever any symptoms. We certainly wouldn't ever think about any kind of surgical treatment. We think about surgery for patients who just can't function, who can't manage their symptoms, and also showing severe blockage or any kind of blockage of spinal fluid. And in some cases, we'll even do surgery even though we can't document the blockage of spinal fluid on a cine MRI. So the decision to operate is not so black and white. It's real easy when somebody comes in with a severe Chiari, severe blockage, and severe symptoms, right? That's an easy decision. The other end of the decision-making process is someone who has very minimal Chiari and very minimal symptoms. It's the spectrum in between that becomes very difficult, and there's no strict algorithm, there's no strict formula, and there's not strict agreement among surgeons about when you do surgery, in fact, what kind of surgery that you might do. And there's a couple of different ways to doing that. So there are basically, when we don't know the cause of something, can't eliminate it, and it's bothering you, we try to treat it. Okay, so pain medicine, aspirin, Tylenol, lifestyle changes, avoiding the things that aggravate it, physical therapy, restricting your activities, maybe changing your job, and other things which Lisa will talk about. So one of the things we know, if you have a Chiari malformation, there are a few things that you should avoid. You should avoid any kind of neck traction. You should avoid any kind of manipulative treatments. And I think this is one area where probably chiropractic treatment is not so recommended. In fact, chiropractors may not be familiar with Arnold-Chiari malformations. So we have to be careful about the things that we do and question each thing in every decision that we make. Avoiding spinal taps, and spinal taps are done commonly, but spinal taps sometimes remove a lot of spinal fluid and cause a Chiari malformation to actually get worse. Spinal tap is done by putting a needle in the lower spine. So we're very careful about invasive procedures, and you certainly always need to talk to your doctor, and if the doctor isn't versed, don't be afraid to ask for another opinion or to get somebody else to take a look at it. So Lisa is now going to talk about non-surgical options.
Thanks, Dr. Tobler. So we definitely at Mayfield have worked with the physicians to come up with a little bit more of a team approach, and I think that that's worked out real well for our Chiari patients because, as most of you know, not everybody's surgical. And so we needed an option for these people as far as where are we going to go with them. So typical physical therapy appointment, most everybody's had some type of physical therapy in their lifetime or someone in their family, but for Chiari it's a little different. Yes, we assess your weak muscles, strength, test, everything like that, but we're also going to look at things that will optimize your cerebrospinal fluid flow, right? Because that's number one. That's the number one thing we need to look at. So we do treat for modalities. We do some dry needling in our clinic, a little bit new in the world of physical therapy, and we do a lot of manual work. But the number one thing we want to look at is how do we get the pain under control? So looking at the pain cycle, everybody in this room that's had some Chiari issues could probably relate to this. And somewhere along the line, we got to break that pain cycle. So that's the biggest thing we look at in physical therapy. What can we do to help you start to break that pain cycle? And there's a lot of different things. I have a lot of educational pieces up here, but it's a lot of day-to-day stuff. And Dr. Tobler referred to the fact about the pistonine of the tonsils. So how do we eliminate that? How do we settle that down so that you will get the optimal cerebrospinal fluid flow and take away some of the symptoms? And that some of that is avoid traumatic activities. Unfortunately, sometimes we have to make lifestyle changes, talk about cushioned shoes, what kind of activities are you doing? Some of our patients always say, I had a mom call me recently and say, well, can he ever go dance and jump up and down? And I said, well, maybe not. Does he want to have symptoms, or does he want to, wake up tomorrow feeling good? So there's some things, unfortunately, we just have to eliminate. We know overhead activities are not good. Kind of pushes, compresses down in the area where the tonsils piston, and we try to take those things away. So even though people are in the gym saying, I'm on a lifting program, this is the first thing that we start taking away. Sitting at the computer, body mechanics. We preach this in our clinic a lot. Ears over shoulders over hips. Computer eye level. So look at those things at home even. Computer screen, eye level, keyboard a little closer, mouse a little closer. What do we all do? Even when we drive, everybody comes forward, so we want you upright as much as we can get you. Vacuuming, everybody's favorite, staying upright. So we tell our patients, don't lunge. Stay upright, shorter strokes. Change the way you do things at home. Dishes. You can see here what we did is we opened the door, put a leg up, prevent you from bending forward so much of the neck. What happens when you bend forward the neck? Right? You're changing the position of where that cerebellar tonsil comes down. So lifting. See how upright her head is here compared to here. Protecting your neck. Keep it a neutral position. Like I alluded to, driving in the car. That's one place where I always see women like this, who are really far forward. Sitting in recliners with a high back footrest. I even tell my patients, look for your rest behind you in the car. Feel for it. Keep telling me where it is. because that way I know you're always trying to sit upright and sit back. We talk about this a lot in PT, tech neck. So everybody's cell phones, right? Everybody's got them out in front of you. Keep them up. Everybody's got their readers now. Same thing. Find ways to get them up in front of you. Take away this positioning and all those things that you do at home. This is a great picture that just shows the stress added on. As soon as you come forward just a couple inches, look how much stress is put on your neck. And so if you think about that with day-to-day activities, if that stress is increased, what does that mean is happening at the tonsil level? What's happening at the cerebrospinal fluid level when your neck's in that position? It's really going to change things up. And you're going to increase your symptoms. So that's the whole process of everything that we try to teach you in therapy, is try to take away your symptoms. So what can we do? I've given you a lot of don'ts. We do take our patients into weightlifting. You can see here she's pulling down. So that's the difference. We want to work the lower muscles. We want to get away from that neck. The difference with walking and the elliptical, less pounding, right? So we try to give you things. I try to keep patients off the stepper. A lot of movement, a lot of bobbing up and down. We try to take away those kind of activities. Just more exercises. Again, I've got these on paper if anybody's interested, so we've got a lot of the exercises around. Stretching. We talk about this a lot with our airless Danlos patients because everybody thinks that maybe they shouldn't stretch because they're hypermobile. What they have to remember is it's not the muscle that's hypermobile, it's the joint. The muscles can still be very, very tight. But that means we also need to teach you to stretch properly. So patients come in our clinic a lot of times and they've had therapy somewhere and they tell us it made them worse. And we get that because they probably weren't taught to stretch properly. We're very adamant about pulling down on the shoulder and then moving the neck, as opposed to me just moving my neck. Look how much more movement I have compared to what she's doing if she depresses her shoulder. So now we're not getting all that neck movement. We're not pulling on the tonsils. We're not aggravating things. We're not creating symptoms. So we are very adamant about positioning. Again, another stretch that we give, chest stretch. We talked about everybody wanting to be upright. We say ears over shoulders over hips. The only way you're going to get there is we make sure that we're stretched. Also can help with the tingling numbness in the arms and legs if we get into stretches. We've found a lot of symptoms with our Chiari patients, some of those even being jaw pain. So we've started addressing a whole lot more in jaw pain. Dr. Tobler talked about where the nerves come out through the face. I'm going to talk a little bit more about dry needling here in a minute. We're also finding that if we kind of get near those nerves with even the dry needling, that we're making a lot of changes in facial pain, ringing in the ear, tingling numbness, things like that. So sometimes just self-massage is good because you're going to help break that up. This is going inside the muscles internally, inside your jaw. Just another way to help alleviate jaw pain, alleviate some of the TMJ pain. And actually, we've had good results with this with the ringing in the ear as well. So, improving your sleep. We talk to patients about this a lot, and this is a big one. If you can't sleep, you don't feel well, and we know this. So there's a lot of things we go through. I've got a few pillows up here that we recommend. Some of them are for headache control, some are for positioning. But we'll talk about that with this. If you look at positioning, again, we're trying to keep everything in alignment. See, everything's nice and straight. The biggest mistake we feel like people make is they don't support their neck. They support their head, but they don't support their neck. And that's what this is all about. Again, where the tonsils come down, the upper cervical spine, and that's where we want to support that neck. Other tricks. I know Dr. Tobler kind of alluded to this. We talk about bowel movements, eating plenty of roughage, not straining, okay? Minimizing head motion during brushing. I showed you the picture of where we had the leg up, so she didn't have to flex forward. Keeping that head out of that, position again. And then, I don't know if anybody has seen these, but they do have these special trays at the beauty salon. And we recommend that you do that. It definitely is a way to try to keep down. This is a horrible position for somebody with Chiari to be in. I call this my home alone picture. If you're going to cough or sneeze, we tell our patients, try to brace. Get ready for it. You're not going to catch it all the time, let's be real. Coughing and sneezing comes on very quickly. But if you're sick and you know it's happening, there's nothing that increases the symptoms worse than coughing and sneezing. So we try to teach our patients to brace it, catch it, not whip it at the neck. You just don't want that. You don't want that force. Balance, another biggie. So we know there are a million symptoms. Thank you, Nicole, for saying that, because I was one of that therapists years and years ago that probably said, are you crazy? But now I know, and so I have a passion for this, I feel like, because we didn't do patients justice in what we were doing, and there are a million different symptoms that we need to address. And I actually have started in our clinics that we're starting a list, and we want to go down every single one of them with you. And I think it's affirmation for our patients that we know you have these, and we need to address them, and we need to go through them. So, yes, you're right, and I think it's great that we're finally figuring this out, and we're trying to educate more physical therapists to what's going on with these patients so we can do more for you. And with that being said, Dr. Tobler is going to come back up. I'll give you that.
Well, thank you very much. So now we're going to address a little bit more detail about Chiari decompression surgery and what it actually is and how we do it. So again, the treatment, the indications are when these symptoms are unmanageable and we see CSF blockage, we see syringomyelia, we see significant tonsillar descent. There's a lot of hard decision making when symptoms or findings are less than the obvious. So the goals of the surgery, what we do, we're really just structural engineers. What we're trying to do is refloat the brain, get it out of the foramen magnum, and establish the normal flow around the brainstem as it leaves through the foramen magnum. So we can have a perfect picture of doing that. So our MRIs, and they're great anatomy, and they can show us that we have a perfectly reconstructed foramen magnum and there's no flow blockage, but patients still have some symptoms. So there's not always such a close association between we'll have surgery and fix everything. This is not like putting a new set of tires on your car where they should be perfect. So the outcomes vary from surgery to surgery and patient to patient. So the goal is to decompress the posterior fossa. And so we do that by making the opening larger. We remove some of the bone at the foramen magnum, we remove it upward, and then looking at this front to back picture of the skull, we actually take a sort of circular lunar portion of the skull bone out, and we have very special drills that actually help us to accommodate that. And then, not always, and it varies from case to case and surgeon to surgeon, sometimes we actually open the dura. The dura is the membrane that the brain and spinal fluid float in. That membrane is a very thick, almost like a leather-like membrane. And we actually cut it open and sew a patch in there to make it bigger. So we remove the bone and we expand the sac. And sometimes we even do a little bit more than that. Sometimes we actually shrink up or remove a little bit of the tonsil, the part of the brain that's coming down. Fortunately, that part of the brain, as far as we know, doesn't have any discernible function. So it can be partially resected or removed. So these are the steps. Opening the skin and the muscle after the patient's positioned correctly and put asleep, by the way. And then we remove the bone. And then sometimes, most of the time, I remove the first cervical bone, the lamina of C1, and we'll show you that. And then we open that dura. And then inside, we sometimes dissect a secondary little membrane that's in there that may be responsible or may partially block flow. And then removing or resecting or shrinking down the tonsil when surgeon decides to do that, then sewing in the patch and closing all the muscles and being done. So surgery is very stepwise and it's very precise, and it should be very precisely planned. This isn't the kind of thing that you go to the operating room and say, well, we'll decide when we get in there what we're going to do. Sometimes you do make a decision that you change your course during surgery, but most of the time you have a very firm plan. And so The patient is placed in this clamp, and this is called the Mayfield clamp, by the way. It's used worldwide, and it was developed and invented here in Cincinnati by Dr. Mayfield. And the patient is very securely fixed to the table. You obviously don't want your neck and your head flipping around during surgery, so very precise fixation. We usually shave a little bit of the hair and make a vertical incision, so we make an upright incision. And then there's muscles under there. You can feel all those muscles. They're thick bands of muscles in the back, so we have to spread those apart. We have little devices that hold those spread apart, and then we actually expose the bone and then cut out a section of that bone. This is the C1 lamina. So it's an arch of bone, and sometimes the tonsil is herniated down below that. So in those cases, we actually make a cut in the bone here and here. We can remove that, take it off. We don't need it. It can be removed. So there's various measurements that people use. This measurement here is about 3 centimeters by 4 centimeters. I generally make an incision up to about 2.5 centimeters. Too much can cause the whole cerebellum to kind of herniate or fall down. And then once the bone is removed, we see that dural membrane. And in this illustration, you can see where that arch of C1 has been removed. So we make a cut in the bone there and there. This is C2, and there's 7 cervical vertebrae. Now we make an incision in the dura, and once we make an incision in the dura, which is here, you actually see the brain. And it's a profound experience to see that highly magnified in surgery under the microscope. What you don't see here is that brain is pulsating with every heartbeat. It's quite dynamic. So we put a suture on there and pull that membrane, the dural membrane, aside. And sometimes we bring an ultrasound machine. An ultrasound is a probe. Most of you have had an ultrasound. And it gives us this kind of an image. And we can actually, before we open the dura, we can do an ultrasound to see if maybe the pistoning has stopped. Sometimes just taking the bone off is all that a surgeon does. Doesn't even open the dura. But ultrasound is very helpful in showing that you've improved the CSF flow. This is kind of commonly used in children for pediatric surgery. Now you can see here, opening the arachnoid, that's that thin, it looks like cellophane. It's another thin membrane, and it can be restrictive. It can restrict the brain. And so some people open that, some people don't think it needs to be open. But there's the cerebellar tonsil on the left and the right. And right there, deep to that, is where that little opening is, that little slit that goes down into the spinal cord. So that slit opens up and expands when the flow is blocked around it. And they're showing that, retracting that right there. And so sometimes part of the operation is we take these hot pincers, these forceps, and we actually burn and shrink up and resect part of the membrane to open this little opening. That opening is called the obex. Spinal fluid flows down the obex, and you can see it illustrated right there. It's a very beautiful picture. You see the pulsation of the brain? See how it's pulsating. So after we've opened it up, we take an artificial membrane. There's some manufactured artificial membranes, and then there's some membranes that actually come from animals. Typically I use what's called bovine pericardium. It's the pericardium from a cow. It's not a living membrane, it's tissue that's been processed. And you see it's kind of an elliptical or football-shaped opening. So this requires very meticulous surgical technique. And you can see how that membrane is sewn into place. That's extremely important because you have to have a watertight seal. You can't have that pulsating spinal fluid leak through that membrane. So there's what the dural patch does, is it opens, it creates bigger space and it opens up into the defect where the bone is removed and it's not replaced. And the muscles are closed down over that, and it heals up very nicely. And what you see here in the green is a little spray sealant. So we have a little like super glue kind of sealant that we use to help stop any spinal fluid from leaking. So when you go home, you know, we tell you make sure you don't cough and sneeze and strain very much, because we don't want CSF to start leaking. It could actually leak through the wound and come to the outside, and you can get meningitis. And that's a very serious condition, and you need to go back to the hospital and have a revision surgery to seal that off. Thankfully, our techniques and experience are so developed that that rarely happens, but that can be a life-threatening situation. So there's what it looks like post-op. And so there are complications that can occur. The spinal fluid leak, it'll never be zero, but we do everything we can do to drive it as close to zero as possible. The infection rate is around 1%. Major complications like a heart attack or a stroke or something cataclysmic happening is extremely rare. You could die from this surgery. So the major total complications are around 1%. There are certainly minor things that, rather than calling them complications, they're sort of post-op. You're going to have a sore neck. It's going to be very painful. You can have headaches, neck pain. You know, like any other surgery, you could develop some pneumonia or urinary tract infection. So we do everything possible to prevent those things from happening. But everybody has a certain amount of pain after surgery. Severe nausea is very common. And everybody has nausea after anesthesia to some extent. But this is a worse kind of nausea. And this nausea is related to the fact that the nausea centers are right there underneath us in the brainstem where we're working. So those centers are just disturbed by the opening and pressure shifts and changes. So severe nausea, we usually get the better of it in about 24 hours. So that's our other concern is other complications from anesthesia, such as lightheadedness, which is related to blood pressure problems that usually easily well managed and temporary. But the CSF leak is certainly one of the things we're very concerned about. We tell our patients about it. It can occur on a delayed basis. So you could be home 5 or 6 days after surgery, and you could have a slowly developing CSF leak. And what happens is the back of your head can start swelling up, and it looks like somebody's got a golf ball under your skin. And then sometimes it can break through and start leaking. So that is something that you have to be concerned about for a period of time, even after you go home. So the long-term results of carefully selected and well-treated surgical patients are good. It's in the 70 to 80% range where I'm really happy. I'm so much better. I may have some symptoms, and the amount of symptoms or problems that you have varies from patient to patient. You may go on for 2 or 3 years after surgery and have virtually no symptoms, and then you may start having some recurring symptoms. So we always have the capacity to reevaluate this by doing another Cine MRI. Oftentimes you'll just routinely get one about a year after surgery so that you have a baseline to follow going into the future. So there are many reasons why you may have symptoms, and that's just simply by the fact that in some patients they've been having these symptoms for years and years and years, and there's a certain amount of programming in the brain. There may be some things physiologically causing persistent symptoms that we actually don't really understand yet. The brainstem has been tugged, it's been tethered, it's been pulled down, and brain tissue does not react kindly to compression or distortion. And there are some other headache syndromes that you have to think about. So as far as recovery expectations, it takes 4 to 6 weeks, and by 6 to 8 weeks, you're usually feeling pretty good. We restrict your activities, and always keeping a diary is a very good thing because it's so easy to forget symptoms or symptom severity, when you're looking back 2 or 3 months. So there are medications. We put a lot of ice, recommend a lot of ice therapy, and of course restrict your activities. So Lisa is going to talk more about the sort of immediate do's and don'ts and post-operative therapy, which differs a little bit from conservative management.
So just real quick, we talked a lot about the do's and don'ts in the beginning, and obviously a lot of that's going to apply post-surgical as well. But we do get started immediately. We try to get patients stretching, because the biggest thing, and I'm sure a lot of people who have had Chiari will tell you, the muscle tension doesn't go away. The surgery corrects a lot of things, but that muscle tension still hasn't become normalized. So we do a lot in therapy to really address that, and that's the first thing we kind of want to get after. We do give you a lifting restriction of 10 pounds, 2 to 6 weeks, say Dr. Tobler, and then we'll gradually increase you as time goes on. We try to restrict your activity, like we've said. I certainly wouldn't put you on a treadmill or anything like that right away. We don't want any of that kind of bobbing. We don't want any kind of pressure back there. But we will start gentle stretches, and we will start some gentle strengthening right away. Again, gradually increasing things as we go on, more exercises we can do. Notice we're, again, avoiding overhead activity. We're keeping everything below shoulder level. We want to strengthen the back muscles in the upper back and close to the neck so that we get that support and we can keep that posture that we need. And that's a lot of what we're going for. Almost all of our physical therapists are certified in dry needling, and this is probably the number one thing that we have found has really helped our Chiari patients. They have responded to it so amazingly well. And I got a quick video we'll show you, and then I'll talk you through a little bit of how that goes. As you can see, we put it right into the muscle belly. The length of the needle depends on where we're needling. Obviously, in this area, we have to worry about the lungs, so we're not going to go real deep. But as you can tell, she put the needle in, we leave it in for a few minutes, and then pull it back out. So what are we looking for? We're looking to normalize tissue again. What does the needle do? It creates just a little trauma in the muscle. We're pulling in blood flow. We could hit a trigger point, break that muscle up. Everybody's got a muscle knot, right, that they've felt before. That's what it's for. We want to break up that muscle knot. We use it a little differently. It's the same needles that the acupuncturists use, but we use it differently in our processes. You can find a PT in your area with a certified dry needling specialist just by Googling it. That would be our suggestion typically. We tell people that we see a lot of people from out of town that come in to see our surgeons. Then they'll come and see us for maybe a one-time visit, and we definitely direct them if they're looking for a PT to try to find one that's dry needling certified. The other thing that we've gotten into a little bit more in our clinics is cupping, and we're finding great results with cupping as well. So, those are two things that I think people can ask when they're looking for a PT group in their area is, do you have somebody in your office that is capable of doing those things?